with a complaint of hematuria, 2 episodes, 1 month back.
Okay. So I want to know the type of hematuria, whether it's total or initial or terminal or and associated with pain or not, and any associated with clot or tissue passage, and any history of low urinary tract symptoms, and any history of hospitalization for this hematuria.
Okay, fine. Hematuria was gross, painless, total, associated with blood clots, not associated with tissue beads, not requiring blood transfusion or no hospital admission at that time. Then no history of flank pain, flank swelling or fullness, fever, lower urinary tract symptom, pyuria or lithuria. No history of weight loss, loss of appetite, cough or breathlessness.
Okay. Any history of fever? No fever. Hello?
Yeah, no history of fever.
Okay. How many episodes? Just
2 episodes, 1 month back.
any previous episodes prior to that?
No previous episodes.
Okay. Then he's got any lump in the abdomen?
Why do you want to know about previous episodes? If patient has hematuria for 6 months, it could be other diagnosis. If he has only 1 episode, it's of a different diagnosis. Is this possible?
Yes, ma'am. Even low-grade TCC can be present for a long time.
Mm-hmm.
So patients may have intermittent hematuria and they may not be bothered.
Okay. Any other reason? It's likely to be benign, na? If it is present for a year or so and it is going on and off, because otherwise the patient will present with some other secondary symptom like pain or a lump or something more sinister if it is malignancy.
Oh.
Okay, what else do you want to ask?
Does he have any lump in the abdomen? Any feeling of lump in the abdomen? I want to know. Yeah.
No flank pain, no fullness,
Oh.
no swelling.
Okay. Then I would like to ask about his comorbidities and personal history.
Mm-hmm. So you have finished all you want to know about the patient in present history.
Yes, ma'am.
So
Yes.
you may have come to some diagnosis then.
Since it is a painless hematuria, 55-year-old male, so my diagnosis would be either CA bladder or the RCC or TCC. No? Right up.
So you answered your question as it would be CA bladder, RCC or TCC. You want to correct it? Your statement?
I want CA bladder or renal tumor, renal malignant renal tumor. Maybe either of that TCC.
Yeah, so you don't have to tell whether it is TCC or RCC on history, right?
Okay.
What else do you want to know about this patient? Apart from his past medical history. Show him past history.
I want to know his personal history, smoking history, alcoholism, alcohol.
Okay. So he's a known case of diabetes, hypertension and hypothyroidism, pulmonary cox also.
Okay.
So?
He's got no tract symptom, but person no. Yeah. So there's involvement of pulmonary cox is unlikely.
Pulmonary cox is?
Since he has got, at present, he has got no any lower urinary tract symptoms. So PTB can be ruled out.
Can be ruled out. That's a very bold statement. GUTB not necessarily has to present with bladder symptoms. It can present in different forms.
Such a long history, they should have at least some low urinary tract symptoms. Patient has got no symptoms. Or any fever or no other constitutional symptoms.
Okay. Anything else you want to ask?
So I would like to ask about his married history, whether he's married and got children.
What did you say? I didn't hear you.
Whether he's married and got children.
What has that to do with diagnosis of CA bladder?
Since the history of pulmonary COX is there, so that may correlate with any GUTB. That's gives indirect marker. Whether any.
So all patients of GUTB are infertile.
No.
Then why do you want to get into something which is unnecessary? What is the important history which you are not asked here?
Smoking history.
Okay, that is in personal history. I want to know in the past and present history.
In history of hospitalization, already they told no history of hospitalization immaturely.
Yeah. So you want to know whether the patient has been investigated for this symptom or whether any treatment has been offered, because that will give you a different start, right? Suppose this is a case who has undergone TURBT and undergone BCG and now again presenting with hematuria, then it would have a different different diagnosis to start with, right?
Okay.
What else do you want to know? What lower urinary tract symptoms did you ask for?
Increased frequency, nocturia, dysuria, urgency. So none of the complaints is what.
Out of these, which is most important?
Increased frequency and urgency and dysuria.
What did you say? Increased frequency?
And urgency.
If I ask you to tell one symptom in the lower urinary tract, which is importance, what is it?
Urgency.
Urgency, want to think again? What does urgency signify in a patient with CA bladder?
Involve the tribone and bladder.
So that is important. Somebody else wants to answer?
Pain also. Pain during
pain. Pain. Is pain the symptom you ask for LUTS?
No.
Then? What is the symptom which has prognostic implications in CA bladder in the lower urinary tract symptoms? Nobody wants to answer?
Frequency. Dysuria. Carcinoma in situ will have dysuria.
Dysuria is the most important lower urinary tract symptom because it is associated with CIS. It has a bad prognostic implication in
So, patient consumes mixed diet, sleep, appetite normal, bladder and bowel habits are normal. Patient is a chronic cigarette smoker, 8 packs years, and he is chronic tobacco addict for 40 years.
What is the pack here?
I couldn't hear you.
What?
Hello.
What is the pack here?
Your package is the number of cigarettes smoked per day for a year. It's 20.
Number of cigarettes means if suppose I smoke 1 cigarette, then it is 1 pack here, is it?
20 cigarettes per day for 1 year.
How many?
20 cigarettes per day for 1 year. That's 1 pack here.
Why is the figure 20?
So a pack contains 20 cigarettes.
Because 1 pack contains 20 cigarettes. Pardon? Okay. Now it is 10 it seems. But okay, so what is the implication of cigarette and tobacco addict?
The more exposure of cigarette smoke causes increased risk for the malignancy in both bladder.
So CA bladder is concerned with cigarette smoke or tobacco addiction?
Tobacco in any form, but cigarette smoke is more implicated.
Tobacco in any form is implicated in CA bladder?
In any form, yeah, but cigarette smoke has got more implication.
Why? Cigarette smoking should be considered with for the lung, right? Direct exposure. Why for the bladder? What is the mechanism?
It is the polycyclic aromatic carbons, they induce a variety of P10, P53 mechanism, and they alter the P53 mechanism. The renal cancer is the VEGF and the HIF. That's how they induce the mechanisms for malignancy.
So what is it with P53? What happens with P53?
P53 has got so it got a mutation. So the tumor suppressor will get affected.
Any other mechanism for cigarette smoking?
For hypoxia inducible factor, it will affect the increased hypoxia inducible factor. So which in turn will cause VEGF augmentation and causes a kind of malignancy.
No concern with the bladder.
Bladder is
Bladder and cigarette and tobacco. This is the other mechanism. I had stopped asking these questions. I thought you all know all the answers for it. Yes, Nirmit, you know?
And nicotine products are excreted through bladder web, that's why it causes P53. Yes, ma'am. Surface.
hello.
Yes, yes, ma'am.
Hello.
Hello. Yes, ma'am is asking another mechanism.
Yeah, we couldn't
except P53 mutation.
Okay, so not getting answers. So 5-minute presentation next time.
Okay.
Okay. So personal history. So at the end of all this history, your diagnosis is provisional diagnosis is
I can see a blood. See a
still
blood.
CA.
See
Okay.
bladder and the renal tumor, malignant renal tumor.
Both are there. So in favor of renal malignancy, what have you got?
My hematuria.
But that is painless.
Yes.
Then?
And since that's why, since it's a painless hematuria and no low urinary tract syndromes, so I like to have both the cigarette smoking.
No, but what is in favor of renal malignancy? You are putting renal malignancy as your second diagnosis. You don't want to entertain GU tuberculosis. So why is your second diagnosis renal malignancy? Patient doesn't have flank pain, no flank swelling, no serpiginous clots, no lump, nothing.
Yeah, age is 55 years. That's also one of the things why I want to consider. And apart from that, he has got no other history of any lower tract symptoms. That's one main thing.
Lower urinary tract symptoms should put you in favor of the bladder, right? Not of the kidney. No?
Since it's not there, I have told I want to consider this also, both.
Okay. So what do you want to do now?
Yeah, I would like to do hemoglobin and physical examination I want to do.
Okay, then show him physical.
Patient is moderately built and moderately nourished. Patient is conscious, well-oriented to time-place person. Patient is afeverite with a pulse rate of 86 per minute, with a blood pressure of 136 by 76. No pallor, icterus, cyanosis, clubbing, lymphadenopathy, or any edema. Skull and spine examination normal. Gait normal. Coming to parabdominal examination, inspection, patient's counter is normal, umbilicus is central, no visible lump, dilated vein or scar. On palpation, abdomen is soft, non normal. Yeah, everything is normal.
Okay, now I'd like to do hemoglobin and serum creatinine. Depending on whether you
Diagnosis is CA bladder and malignancy of the kidneys.
is
Any specific specific finding you want to know on general examination, which he has not told?
an external genitalium, we have to look for any varicocele.
Yeah, you have to ask for genital examination. So it is normal. Irrespective of whether it is any malignancy, you have to ask for genital examination. You can't go and ask hemoglobin. What if he has BXO? Suppose I tell you patient has BXO and meatal stenosis.
Oh,
Then
you have to address the problem also first.
then
But
it would be a problem for you to do a scopy. Huh? So you can't forget genital examination. Okay. Investigations?
I will like to do hemoglobin creatinine.
You only want hemoglobin and creatinine.
First, I want to get diagnosis, so I would like to do hemoglobin creatinine, and based on I would like to do a.
So tell him only hemoglobin and creatinine. Don't tell him anything else. Why is hemoglobin 13.9?
Yeah, it may be because though it can be malignancy, it can be because of the paraneoplastic symptom. The erythropoietin secretion hemoglobin may be high or maintained.
Which bladder malignancies is associated with such a thing which you are saying?
Renal malignancy. I'm telling renal.
But renal malignancies is your secondary diagnosis. Why is the HB 13.9?
He has got only 2 episodes of hematuria.
Yeah, so if he has hematuria, his HB should be low, na? He may be bleeding daily, we don't know. So why is his HB high? Common sense. Yeah?
He's a smoker, so polycythemia will be there. Creat is 1.
Ma'am, we couldn't get it.
HB is 13.9, creatinine is 1, normal.
Okay. So since my diagnosis is more of malignancies, I want to do a CECT now.
CECT of what?
Abdominal pelvis.
We don't want to know whether he is what is his sugar level. Patient has history of diabetes, hypertension. You want to send him for contrast CECT without knowing his sugars?
Sugars.
Past history you asked, no? We told you also diabetes, hypertension and thyroid. Hypothyroidism. Don't you think that has to be investigated?
For sake of diagnosis, we need one. Then
we have to treat the patient as a whole. You just can't say, ki, I don't want to know his sugars before sending him for a CECT. You don't want to know whether his urine has any RBCs?
That glucose we need.
You don't want to know whether he has pyuria? What is his count?
Count is for many symptoms. No constitutive symptom.
So you don't do, is it? Is this what you practice?
We do, ma'am, but first we want
Then
the
if
diet.
whatever you do, you have to tell. It's not that you do an HB now and then after you do a CECT, you will send for CBC. Do you do that?
No,
Is that the practice?
no.
Then you will not do sugars in a patient who is diabetic
Yes,
before sending him to see for CECT?
yes, we said we do, ma'am.
Then who is going to ask?
Yeah, we have to ask. I have to ask.
Show him investigation. You don't want to do cytology? Your diagnosis is CA bladder? And your teacher is Dr. Ganesh?
Since I'm doing a CECT, ma'am, I want.
Since sir is not there, you are not asking. Show him.
CBC suggestive of hemoglobin of 13.9, total counts 8,900, platelet count 3.2 lakh, creatinine is 1.5, SGOT, SGPT normal, sodium potassium normal, ESR 27, LDH 100 and urine routine suggestive of color is reddish, pH is acidic with occult blood positive with numerous RBCs. Pus cells are 12 to 15 per high power field. Epithelial cells are present occasionally. Urine cytology suggestive of negative for high grade urothelial carcinoma.
Okay.
Yes. These are the CT images.
Just run through. Okay. Yes, yes. Okay. Yeah, yeah. Yes. Yeah, yeah. Okay. Oh. Yes. Yes. Yeah, okay. Okay. Oh.
These are the images.
This is the CECT of the abdomen and pelvis. Hello?
Yes, yes, yes.
Yeah. So CECT of abdomen and pelvis, in which left kidney shows its normal size and shape and function, and the right kidney shows heterogeneously enhanced lesion in the lower pole of the right kidney, and there is a dilatation of the pelvic ulcer system, and there are no significant lymph nodes. The IVC appears normal, and no evidence of any tumor thrombus in the IVC. And bladder appears normal.
What is the striking difference between the right and left kidney? Here in this picture.
One is a shape, the renal contour.
It's enlarged. Yeah. Anything else?
It's heterogeneously enhanced.
Okay.
And even there's a hydronephrosis there.
Okay. Yeah. Anything else? Hmm? Can you find any difference between the contrast uptake on the right side and left side? And why is it so? Tell me possible reasons for it. Isn't there a difference or you don't appreciate it?
Yeah, we can easily appreciate it.
Yeah. So the contrast uptake on the
Hmm.
left side is prompt and it is dense. You can see all those
Yeah.
parts of the cortex and medulla. While on the right side, nothing is appreciated. No renal architecture is properly appreciated.
Yes.
Oh. Is there contrast in the PC system on the left side?
Very good in the way. So,
See again. See again. Show him. Show him.
very
Could you delineate the ureter or pelvis with contrast?
upper cuts we can see. The lower cuts we are not able to see exactly.
Why is this so? Why is there a difference?
The tumor will be more occupying the whole, including the PCS.
Involving the PCS? No, you can see the PCS very clearly. Show him the, go down.
And the lower cuts on.
Go down. See PC system.
Yeah, as we go,
Pelvis is properly outlined. Go down.
as we come down, we couldn't. Until this we can see. Below this we are not able to.
Show him the reconstructed image. So why there is a difference? What are the causes when the kidney doesn't take an uptake of contrast?
Is there any relation between hematuria and contrast uptake?
The PCS.
Hi Bobby, are you around?
No, sir is not it.
Okay. So what are the causes when there is no contrast on one side?
This non-functioning kidney.
Non-functioning due to what? What is happening that there is no uptake of contrast?
Then necrosis and fat.
Why the? I want to know what is the pathology. What are the reasons when? Okay, non-functioning kidney on any of this imaging. What are the reasons?
With long-standing stone or with HTP, all this.
What does long-standing stone signify?
It can cause
Huh?
HGB, can cause HGB.
It signifies obstruction. So obstruction is one reason. Obstruction of the PC system or the ureter by anything can be one reason. What else is the reason when contrast doesn't go in the kidney?
Renal ischemia.
But why? Why is renal ischemia occurring? Basic reason is why.
Did you say IVC there? We improved.
So,
Show him the cuts where the IVC is there. Oh, when there is. Haven't you seen this situation not in concern with malignancy but any other this thing? You've seen it in trauma. If the renal artery is damaged, there is no contrast. If the renal vein is thrombosed, there is no contrast. If the PC system is obstructed, there is no contrast uptake. So one of the three could be happening here.
Oh.
And you need to see whether you can see anything which is contributing to that. So you need to see the artery properly, the vein properly, any cuts related to it, anything related to the ureter.
everything, the vascular structures appear normal.
Okay. What's happening in this cut?
Yes, it's really, I don't, right side, I don't know if it's the menu, I don't know if it's.
No. This cut is specifically showing you some part of the vasculature of the kidney, no? What is it showing you?
The left side is uniformly uptake is there.
Ray, it is showing you the renal vein. First cut is showing you SMA is going, then the left renal vein is coming. The left renal vein is filled with contrast. The right renal vein is partly filled with contrast.
Oh.
Can you see? Can you appreciate that? Huh?
Yes, ma'am.
Yeah. Okay. So what is your diagnosis now at the end of it? And any other investigations you want?
So renal tumor T3A N0. For M0, I want to do a CCT also with chest also. And apart from that, we have to do liver enzymes. Already we have done that.
We told you liver enzymes, no?
So we will do CCT or chest also. For our metastatic outcome.
You have?
This is HRCT chest. We suggest you of no evidence of any significant pulmonary, pleural, or mediastinal abnormality. Hello?
Yeah.
Yeah.
So it is T3A injury.
You don't want to evaluate the renal vein?
You've seen no.
Hmm?
You've seen there's no evidence of the thrombus. Nothing.
Okay. And even if it is there, it is not entering the IVC. But I think it would be prudent to ask for a Doppler because before operating, you should know properly what's happening.
Oh.
Normally, a renal malignancy is associated with increased blood supply to the tumor, AV malformations. So this is mainly a hypodense tumor. So what are the hypodense tumors you know in the kidney pathologically? Don't tell me ischemia and necrosis.
Lymphoma and lymphoma.
Renal pelvic malignancies are hyperdense or hypodense?
Hypertense.
RCCs are?
Hypertense.
Papillary malignancies of the kidney are?
Hypertense.
Medullary duct tumors of the kidney are?
There will be hypertense.
Lymphomas?
Hypertense.
What else you want to do now?
We have done the staging workup.
Huh?
We have done the staging workup also.
Okay.
This performance status is good. So the stage is PT3A and 0 and 0. So its renal function is good. So we will offer a radical nephrectomy.
Radical nephrectomy. Okay. So what? How do you want to do this surgery?
It can be done open or lap.
Before proceeding to, or because this patient may not be having a good performance status, he had 3 comorbidities, so you need to know whether his,
Assumption before this.
yeah, you need to do his thyroid profile. You need to mention these things. You may say it to yourself in your mind that, yeah, I have thought of it, but you need to say it. Because if he's hypothyroid, you can't take him up for a surgery, no?
Yes.
Hmm. Okay. Steps for radical nephrectomy. What are the structures to be included in radical nephrectomy?
The whole kidney should be extrafacial dissection.
Mhm. You want to do it open or you want to do it lab
Yeah, it depends upon the technical
or
expertise.
robotic?
Yeah,
No, no, no. I'm asking you only.
yeah,
Your
we do
experience.
open.
Okay. Fair enough. Yeah. So what all things will you, which will be your incision? What will you plan?
So
Do you plan to mobilize the kidney and then go for the vessels, or you go for the vessels first? What is your approach?
first it will be vessel, first ligation of the vessel.
Okay, so this is the right side tumor. Where will you like it? Renal artery?
You have to go just renal vein and renal artery is at the origin.
Yeah, so how do you go to the origin?
But skeleton is aorta and IVC. Dissect aorta
Huh?
and IVC. You have to dissect aorta and IVC, and this skeleton is the branches, and you have to clamp and like.
You need to know an area where you will go between the aorta and IVC. No, you can't go from one end to the other. So where will you go? Where will you see this renal artery between aorta and IVC? And before that, what have you to do to see the aorta and IVC?
You have to do medialization of
Huh?
right side, the medial rotation. You have to do in first.
I didn't hear you properly.
Right side medial rotation of the colon you have to do. Right side.
Okay, okay. Colon you will reflect. Then what will you reflect?
Then small bowel mesentery also you have to reflect.
Small bowel mesentery.
The root of the mesentery.
Which mesentery?
Small bowel root of the mesentery. It's root of small bowel mesentery.
Why small bowel mesentery? I think we'll require a seminar on what is radical nephrectomy then. Is it small bowel or some other part of the bowel which you have to reflect? Small bowel mesentery or some other part of the bowel which you have to reflect. It's a right side tumor.
Duodenum you have to do.
Yeah, so cauterization of the duodenum. Then
You have to identify the left renal vein. So cauterization will end with the identification of left renal vein. So that will be the indication.
the left renal vein is a landmark for the right renal artery.
For
I'm
cauterization,
asking. Huh?
for cauterization, you have to do until we identify the left renal vein.
I asked you, where will you go in between the aorta and the IVC for the right renal artery? We have to have a landmark, now we can't keep on searching everywhere. Okay, now tell me what is your view on the role of lymphadenectomy for renal malignancies? For this patient, he doesn't have any visible nodes on CT scan.
But since it is PT3, they can be positive in up to 25% of patients. So though it's controversial, it can be done, and it is clinically palpable when you're doing the surgery. Since it is radiologically not seen, so at the time of surgery, when
Will you do it or will you not do it?
Yeah, you have to do it.
You have to do it. Why? Tell me the reasons.
Since it's a T3A, that's one of the indications.
Does it have an implication on the prognosis?
No, it's only for
Does
useful.
it have an implication on survival?
No. It's only staging purpose. It's useful. Otherwise, no improvement in other parameters.
Okay, tell me lymphatic drainage of right kidney and left kidney.
So right kidney, it's paracaval and intra-aortic. Right side and left side, it's para-aortic and intra-aortic.
Paracaval where? On right or left?
Right now.
Right. And on left?
Para-aortic and intra-aortic.
Para-aortic, hilar, para-aortic and intra-aortic caval. And on right it is?
Hilar, paracaval and intra-aortic caval.
What is the upper landmark, medial landmark and the lower landmark for renal lymph node dissections? Anatomical landmarks?
The pressure of the diaphragm to the iliac artery bifurcation to the lower level. Intra-aortic region.
And
apart from that, you have to take the hilar nodes also.
okay, we did the nephrectomy of this patient. Okay. We have his HPF. Oh, so we don't have his HPF. Okay, I think we will call it a day because even I have joined today and have a lot of things pending to do. But I think we need to learn what is radical nephrectomy, what is the role of lymphadenectomy in all the, in N1, in N0, both scenarios, and what will be your approach, what all structures are removed in a radical nephrectomy. So I think this part plus smoking, your funda about smoking and other malignancies of the genitourinary system needs to be clear. Basics have to be clear. So we'll take these two short topics. You divide among yourself, one topic each. Next time we'll complete it.
Okay.
Okay, yeah. Thanks and bye.
Thank you.